I do work with a lot of children with functional neurological disorder and functional somatic symptoms, including functional seizures. So hopefully some of the knowledge that we have gained will be of help to you with your patients in the setting you see. So to understand the treatment of functional seizures, you really need to understand the neurobiology a little bit. So the first part of the talk, I will cover a few points about neurobiology, and then I'm going to talk about assessment and treatment. But before we start, this slide shows you all the different names that are used or have been used for functional seizures. And as you can see, there's a lot of names and a lot of synonyms which have changed over time. And if you're interested in the rationale behind any of these names, you can look at the table of names in our forthcoming manual. And there still isn't a lot of consensus about the names used, but the ones up on the top of the list are really the ones that are more commonly used these days. And this slide shows you how functional seizures fit into functional medicine more broadly. So functional seizures are a subtype of functional neurological disorder, which in turn is a subtype of functional somatic symptoms. I will be using the acronym FND, so remember that it means functional neurological disorder. So now I'm going to give you a quick overview of the neurobiology in kids. Many of your patients will have experienced torture and trauma when they were kids, and these experiences will have programmed their stress systems and the responses in their body and brain. First, on functional MRI, children with FND showed dysregulation in brain networks. And this slide shows you 8 neural networks which were dysregulated in the study we did. And the circles indicate the networks where children with functional seizures showed more dysregulation than kids with other FND. And the factors that modulated this aberrant neural network function included increased body and brain arousal, subjective distress, and HPA axis function. So normally, arousal should increase and then decrease when the stress has gone. But in children with FND, they show persistent activation. And your patients with a history of torture and trauma are also likely to show persistent activation. So Mirjana Askovic at STARTS has done work with heart rate variability, and she will tell you that heart rate variability in your patients is low, because heart rate variability tells you about their capacity to calm themselves. Low heart rate variability means high arousal. So building on this research, our fact sheet, we described functional seizures as sudden, time-limited episodes of brain network dysregulation that occurs in the context of high arousal. Arousal in the brain and body refers to the level of activation. In addition, children with functional seizures report increased adverse experiences in comparison to controls. Other studies show that they also report more maltreatment events. And of course, these findings in children parallel your patients with a history of torture and trauma. They also have more adverse life experiences, and especially those that fall into maltreatment, torture, trauma categories. Cortisol is a stress hormone and the end product of the HPA axis. Our child patients with functional seizure show lower cortisol levels on awakening or a reversed cortisol awakening response. And these findings are consistent with chronic stress, which is associated with an attenuated or dysregulated HPA axis. And your patient's HPA axes have also been presumably activated time and time again with stress. The final product of the HPA axis, cortisol, is a glucocorticoid. It enables the body to provide high levels of energy in the short term, but in the long term, it facilitates epigenetic programming in body tissues and in the brain. So what this means is that individuals who've experienced a lot of past stress are epigenetically programmed to respond with an amplified stress response in the context of future stress. And this idea is really important for understanding functional seizures. And here's a summary slide of the etiology for functional seizures, what we hypothesize to be going on. And if you look at the slide, you can see that your patients have all the risk factors. And this slide tells you what I think is going on. The brain is an energy-hungry organ. We know that children with functional seizures are in a state of increased arousal, both in the body and in the brain. And your patients are also very activated. I think that when energy demands exceed what is biologically possible, for example, when the individual experiences a new stress, real or perceived, neural networks dysregulate and functional seizures are the outcome. The brain then resets itself and the functional seizure subsides. And here I might just say that functional seizures present in many, many different ways. It's any presentation that mimics what an epileptic seizure might look like. For some people, this includes shaking of the body. For some people, it includes changes in consciousness. For some people, it includes zoning out. For some people, it includes other presentations of collapse or of unresponsiveness. So there are many, many different ways in which a functional seizure can present. And we know that your patients are also very activated and that they oscillate between states of arousal, states that are very high in the red and states that are very low. And we know that they can really struggle to stay in that green zone, the window of tolerance where arousal is optimal for daily function, not too high and not too low. And when they go into the red zone, this is when they may be vulnerable to experiencing functional seizures. So now let's talk about assessment and treatment. I think in adults, you will follow the same set of steps that we follow in children. The key difference is that you may be assessing the person as an individual, whereas when working with children, we assess the child as part of the family. After the family assessment, we also do an individual assessment with the child. So step A is assessment and diagnosis by a neurologist. A neurologist provides the diagnosis of functional seizures after conducting a neurological examination and an electroencephalogram, or EEG. And a video electroencephalogram is preferred so that if the patient has a functional seizure during the EEG, you can actually see the seizure in the video and see that there is no epileptic activity on the EEG. So what's really important is that you cannot make a diagnosis of functional seizures. And you also can't accept a referral for treating seizures until you know what sort of seizures they are. You can treat functional seizures only. Epileptic seizures need medications from the neurologist. Epileptic seizures also infrequently cause death. So you need to have a formal assessment, a formal positive diagnosis of functional seizures from a neurologist. Step B is a biopsychosocial assessment. So when working with children, we obtain a developmental history, a story of the child's life and what has happened to them. I presume you also gather this sort of assessment in individual survivors of torture and trauma. This will give you information about the adverse life experiences that the individual was exposed to. You do not need to know what happened in great detail, but a general understanding of the individual's story is very helpful. Step C is psychoeducation. This involves providing an explanation about functional seizures. Our manual will have an English version of the fact sheet, but also other languages, including Kurdish. You should be able to use our fact sheet for your patients. Here is what our fact sheet says. And then you can use a variety of metaphors to explain functional seizures to your patients. When I present these, please pretend that you are Mary and that I am talking to you. This is one metaphor I use. Now pretend I'm speaking to you, the survivor whose name is Mary. Mary, this picture shows you what is happening in your brain when you have a functional seizure. There has been a lot of research into functional seizures in the last 10 years. Our current understanding is that functional seizures reflect a temporary disruption of brain networks. The red ball represents the brain's stress systems, the parts of the brain that activate with stress. When the red ball becomes too big and too strong, it can disrupt motor function, represented by the pink ball. The red ball causes the brain to dysregulate. This results in a temporary loss of control in shaking, twitching, trembling, or jerking, just like you experience during a functional seizure. Once the seizure is over, the brain reboots. It returns to normal function. The red ball is activated by a broad range of physical or psychological stresses. Physical stresses include illness, injury, or medical procedures. Psychological stresses include friendship difficulties, stress at work, stress in the family, and so on. All traumatic events activate the stress systems in the brain. The treatment for functional seizures involves mind-body strategies that help the stress system settle down. The red ball gets smaller so that your functional seizures are no longer triggered. And we will also need to address some of the stress in your life that activated the red ball in the first place. Some of the stress is affecting you via memory, and some of the stress is happening in the here and now. I particularly like this metaphor because I find it easy to use to share the formulation with the individual. And so here's a formulation in visual form. And with each individual, you would need to depict factors relevant to that particular individual. So here is the second metaphor I use, the children going wild metaphor. I use this with individuals whose functional seizures present as blanking out episodes, zoning out, syncope-like episodes, long periods of unresponsiveness, or functional seizures which keep changing presentation. Again, pretend that you are Mary and that I am talking to you. Mary, this picture shows you what is happening in your brain when you have a functional seizure. There has been a lot of research into functional seizures in the last 10 years. Our current understanding is that functional seizures reflect a temporary disruption of brain networks. In the picture on the left, the mother figure represents the prefrontal cortex, the control area of the brain. The child figures represent brain programs in the basal ganglia, midbrain, and the brainstem, lower down in the brain. When all is well, the mother, prefrontal cortex, maintains control over the children, the lower programs, and she maintains regulation between brain networks. Now look at the picture on the right. In functional seizures, the mother goes offline in the context of stress-related changes. Regulation in the brain networks is lost. When the mother goes offline, the brain no longer works properly, and you can zone out, lose consciousness, or fall down. Sometimes the functional seizures can present as shaking, twitching, trembling, or jerking. And sometimes with very little children or with adults who are cognitively challenged, we use explanations that are very simple. This is the autonomic system metaphor. This visual representation is our functional diagram of the autonomic nervous system. The red arrows reflect the sympathetic system, and the red ball in the brain reflects the brain stress systems. We may say something like this. Mary, when the stress systems in your body and brain activate, see the red arrows in the body and the red ball in the brain, then you can have a functional seizure. Your brain cannot work properly and your body trembles and shakes. So we need to help you calm down your stress system in your body and brain, the red arrows and the red ball in the brain. When you are able to calm your body and brain, the functional seizures will settle and go away. We sometimes use the panic attack metaphor. We say that functional seizures are an extreme form of panic attack. The normal panic attack activates the stress systems in the body, causing a high heart rate and sweating, as well as racing thoughts in the brain. In functional seizures, the brain networks are also affected. They dysregulate and cause a functional seizure alongside stress system activation in the body. And this final metaphor, the pressure cooker valve metaphor, was developed by the Salford Royal Foundation Trust. This metaphor goes something like this. Functional seizures are like a pressure cooker valve, a regulator of tension and arousal. Emotional and physical stress builds up in the body and brain. The pressure cooker lets off steam in the form of functional seizures to regulate arousal, enabling the overactivated brain to reset itself back to a regulated state. So all these metaphors and potential scripts will be available in this upcoming manual. So step D, the next step, is the patient's acceptance of the diagnosis. To engage in therapy around the functional seizures themselves, the patient needs to accept the diagnosis. If she or he does not accept the diagnosis, then the neurologist can organise a second opinion. It can be very difficult for you as the therapist if the diagnosis of functional seizures is not accepted by the patient. They may have difficulty in buying into the treatment. Step E is the treatment plan. Our treatment plan for functional seizures has 5 steps. Step 1 of the treatment 5-step plan is identifying the warning signs of a functional seizure. The key therapeutic ingredient of step 1 is the skill set of bottom-up mindfulness, which involves noticing and tracking the felt sense of the body to identify that a functional seizure is coming or is imminent. So most of our child patients are able to sense when their body is activating, when arousal is increasing, and when a functional seizure is imminent. And the same has been found in adult research. The patient may feel an increase in tension in the face or elsewhere, a pain sensation, an increase in breathing rate, a feeling of nausea, tingling sensations, a tension in the head, and so on and so on. In children, we actually use this felt sense of a body to make it up a traffic light safety plan to manage the functional seizures. So step 2 of the treatment plan is to make yourself safe, is to sit on the ground or lie down and make yourself safe. This avoids the risk of falls. Here, you're shifting attention from attention to the body, of noticing the signs, the warning signs of a functional seizure, to the task of getting on the ground. It's very important for the patient to shift attention from the body and from the symptoms of an impending seizure, because attention to functional symptoms makes them worse. So you want the patient to notice the warning signs and then immediately shift attention away from them to the task of making themselves safe. Step 3 is to implement de-arousal calming strategies that help the brain and body calm down, decrease the state of activation. Here you want the patient to focus attention on the task of doing the strategy. They need to have practiced the strategy because they need to implement it now, immediately. Step 4 is to ride out the functional seizure if the patient has not been able to avert it. Step 5 is to implement de-arousal calming strategies after the functional seizure is finished that help the brain and body calm down, decrease the state of activation so that the functional seizure does not happen again. And here is the treatment plan documented in one slide. So when it comes to regulation strategies, in our own work, we start with bottom-up regulation strategies that target the arousal, the increased arousal. These are body-based strategies that help decrease arousal. Slow breathing, grounding interventions, sensory interventions, humming, using the VU sound, and so on and so on. We use these as our first line strategies. Most of the patients we treat are so aroused that their frontal lobes are offline. So cognitive strategies are less likely to work for them. Also, because functional seizures happen in the body, body-based interventions are inherently acceptable to patients. Down the track, you can add top-down cognitive calming strategies. So this could involve imagining a safe place and doing the slow breathing whilst in the safe place, and so on and so on. Let's talk about role of medication. There is no medication for functional seizures, but some of our patients are so aroused that they cannot manage the functional seizures to downregulate the stress system without the use of some medication. And the original use of all the medications on the screen were for blood pressure control, but all of them also help decrease arousal either in the body or in the brain. And sometimes a bit of medication can decrease the background level of arousal so the patient can then use his or her strategies. Once there's some control over the seizures, or the patient can keep him or herself safe, addressing the issues that are driving the functional seizures is the next block of work. And this goes back to our formulation. You then need the long-term work to address the issues that are driving the functional seizures. This might be trauma processing work to process trauma memories, or family work to address violence, or treating anxiety or depression, and so on and so forth. And this is just my last slide, just giving you a visual of the resources. The Functional Somatic Symptoms book is available currently, and the manual on the right-hand side is coming out shortly, hopefully this year. So thank you very much for your attention.